You are staring down the barrel of the MRCS.
And time is the one resource you absolutely do not have enough of right now.
Exactly. We know exactly where you are sitting. You are prepping for a grueling exam, you need high-yield facts, and you need them delivered with zero fluff.
No wasted time.
Right. That is exactly what we are doing today. We are launching straight into a rapid-fire revision deep dive tailored specifically for you, the surgical resident.
Our mission today is simple: to master the clinical anatomy of the abdomen, pelvis, and perineum.
We are focusing purely on the structures, the relations, and the embryological anomalies that constantly trip up candidates. But before we start the clock on the questions, head to www.medsyncltd.com to get their surgical simulation kit, including suturing kit, microsurgery instruments, and more.
Essential gear for keeping those hands moving while you study.
Absolutely. Okay, so the format for this deep dive is going to be direct question and explanation style. I have a stack of revision material here, and I am going to fire classic anatomical scenarios at our resident expert.
I'm ready for it. We are going to unpack the exact details you need to visualize in the exam room. Let's get right into the embryology of the gut tube.
Always a favorite.
Yeah, and looking at the notes, there is a very specific statistic regarding neonates that just jumps right off the page. It says that the vast majority of esophageal atrechias follow one specific anatomical pattern.
Ah.
And you break down what that most common type is. And, well, while we are on the topic of embryology, the material also brings up Meckel's diverticulum. What's the exact embryological remnant responsible for that?
Let's start at the top with the esophagus. Audio is actually a fantastic way to learn this because it forces you to build the 3D model in your mind.
You have to see it.
Right. Picture the developing trachea and esophagus in a neonate. The most common type of esophageal atresia, and this accounts for a massive 8% of cases, features a distal tracheo-esophageal fistula.
Distal.
Yes, distal. It is highly testable precisely because it represents the overwhelming majority. The proximal esophagus ends in a blind pouch, and the distal esophagus connects directly to the trachea, which obviously presents immediately with feeding issues.
Aspiration, exactly. Now, moving further down the developing gut tube, let's look at Meckel's diverticulum. What we are visualizing here is a failure of a very specific temporary structure to disappear.
The vitellointestinal duct?
You got it. In the embryo, there is a connection between the primitive midgut and the yolk sac. That connection is the vitellointestinal duct. A Meckel's diverticulum is simply a persistent communication, a leftover remnant of that exact duct.
And the notes mention a fascinating clinical application for why that specific remnant matters so much in a surgical setting.
Because it's not just an anatomical quirk.
Right, it's a hazard.
Right.
That fibrous cord attaching the diverticulum to the back of the umbilicus essentially acts like a built-in trap within the abdomen. It creates a fixed point.
Which the bowel does not like.
No, it doesn't. So instead of the small bowel being free to move, you can literally have the bowel twist around that fixed fibrous cord.
Creating a volvulus.
Exactly. It's a perfect example of how an embryological leftover creates a mechanical surgical emergency.
It's pure mechanics at that point.
Speaking of mechanics, let's move from the gut out to the abdominal wall and the fascial planes. There is a classic clinical scenario in the text that caught my eye.
Let's hear it.
Imagine a patient comes into the emergency department with a severe straddle injury resulting in a ruptured bulbous urethra.
A urology nightmare.
Yeah. The material states that the extravasated urine will track into the scrotum, into the perineum, and up the anterior abdominal wall. But it explicitly points out that the urine will definitively not track down into the thighs.
Not a single drop.
Anatomically, what is creating that barrier?
This is a brilliant scenario because it forces you to understand the continuity and the boundaries of superficial fascia. In the lower abdomen, the superficial fascia isn't just one layer, it splits.
Camper's and Starpers.
Exactly. You have a superficial fatty layer, which is Camper's fascia, and a deep, much more membranous and fibrous layer, which is Scarpa's fascia. Now, follow Scarpa's fascia downwards.
Over the penis and scrotum.
Right? Extends down. And as it moves into the perineum, it changes its name to callus fascia.
Yeah.
So you have this continuous potential space deep to this membranous layer.
A completely connected pocket.
Yes, but here is the critical boundary, the absolute brick wall that answers your question. Scarpa's fascia firmly attaches to the deep fascia of the thigh, the fascia lata, exactly 2.5 centimeters below the inguinal ligament.
2.5 centimeters below.
Exactly.
So we can think of that firm attachment line right below the inguinal ligament, almost like a watertight seal holding everything back.
That's exactly what it is.
If a patient has a ruptured bulbous urethra, the fluid sits deep to this fascial plane. It just fills whatever loose tissue space is available to it. It gravitates down into the scrotum, and it can track all the way up the anterior abdominal wall deep to Scarpa's fascia.
But the moment it tries to flow inferiorly into the thigh,
It hits that firm, sealed attachment and stops dead.
completely blocked.
And the notes point out you can apply that exact same spatial logic to an ectopic testes in the groin. It physically cannot descend any lower into the anterior thigh because of that exact same fascial roadblock.
The fascia dictates the pathology every time.
Staying right there in the groin area, the material has a massive section on inguinal hernias. It lists all the borders of Hasselbalch's triangle, but, reading a list of borders feels a bit abstract.
It does.
At the operating table, how do we definitively and practically differentiate a direct from an indirect inguinal hernia?
You're right. Just memorizing the borders isn't enough. You have to visualize the mechanics. Think of Hasselbalch's triangle almost like a natural weak spot on the side wall of a tire.
Okay.
You have this anatomical border wall. Let's map it. Laterally, you have the inferior epigastric vessels, inferiorly, the inguinal ligament, and medially, the lateral edge of the rectus abdominis muscle.
The classic triangle.
That is your weak spot. Now, an indirect inguinal hernia doesn't go through the weak spot. It enters the inguinal canal through the front door, which is the deep inguinal ring.
And that's lateral.
Yes, the deep ring is a natural defect in the transversalis fascia, located about 1 centimeter above the midpoint of the inguinal ligament. Because it enters through that deep ring, an indirect hernia definitively passes lateral to the inferior epigastric vessels,
Then it travels all the way down the canal.
wrapped inside all the fascial layers of the spermatic cord.
That paints a really clear picture. The indirect hernia is taking the natural anatomical tunnel, starting lateral to those vessels. But a direct hernia is a completely different mechanical failure.
It's the tire bulging out.
A blowout. It punches directly through the posterior wall of the inguinal canal, right through that weak spot of Hasselbalch's triangle.
Because it comes through the triangle, it sits definitively medial to the inferior epigastric vessels.
So clinically, if you reduce the hernia, apply firm pressure with your finger directly over the deep ring, again, 1 centimeter above the midpoint of the inguinal ligament, and ask the patient to cough.
An indirect hernia is blocked by your finger.
But if a bulge appears medial to your finger, punching through the wall, you know you are looking at a direct hernia.
Exactly. It's a simple, perfect physical exam maneuver based entirely on anatomy.
Let's transition deeper into the abdominal cavity. The notes highlight a very specific space called the Epiploic foramen, or the foramen of Winslow.
Crucial area.
It reads like a dense list of borders, but it emphasizes that this space is surgically critical for hemorrhage control. Can you paint a 3D picture of this area and explain how a surgeon uses it in a crisis?
Imagine you were in the operating room. There has been severe liver trauma, the field is rapidly filling with blood, and you have seconds to act. The epiploic foramen is your target.
Because it's a gateway.
It is the natural window that connects the greater sac, the peritoneal cavity, to the lesser sac behind the stomach. To understand how to use it, you have to know what surrounds it. Picture sliding your index finger into this hole.
Okay, finger is in.
Anterior to your finger is the free edge of the lesser omentum. This is the absolute most critical border because hidden inside that edge is the portal triad.
Common bile duct, hepatic artery, portal vein.
Right. You have the common bile duct on the right, the hepatic artery on the left, and the massive portal veins sitting behind them. Posterior to your finger, forming the back wall of the foramen, is the inferior vena cava.
So you have the IVC behind, the portal triad in front.
Exactly. Inferiorly, your finger rests on the first part of the duodenum, and superiorly sits the caudate process of the liver.
So if we go back to that trauma scenario where the liver is bleeding out, or say you are doing a cholecystectomy and the cystic artery tears, that 3D anatomy dictates your next move.
You pass your index finger into the epiploic foramen.
And you compress that anterior border, the free edge of the lesser omentum, between your index finger inside the hole and your thumb on the outside.
You are effectively clamping down on the hepatic artery and the portal vein simultaneously.
The material refers to this as Pringle's maneuver. It sounds like the most powerful pinch in abdominal surgery.
It will save your patient's life, provided the bleeding is from the liver inflow and not the hepatic veins.
Right. Now, speaking of critical vessels in that exact same neighborhood, the notes bring up a fascinating contrast regarding blood supply.
Okay.
If a posterior duodenal ulcer erodes through the bowel wall, there is a specific vessel directly in the line of fire. But right next door, the stomach can survive having 3 of its 4 main arteries completely ligated.
A study in contrasts.
Let's unpack both of those scenarios. What is that at-risk vessel behind the duodenum, and how does the stomach survive such massive vascular ligation?
Let's look at the duodenum first. The vessel directly at risk from an eroding posterior duodenal ulcer is the gastroduodenal artery.
The GDA.
Yes, it runs vertically, directly behind the first part of the duodenum. If an ulcer eats through the posterior wall, it breaches that artery, and the patient will notoriously present with life-threatening hemorrhage.
Showing up as severe hematemesis and melena.
It's an anatomical ambush.
Yeah.
Now, contrasting that with the stomach, you have an organ that is incredibly resilient to ischemia.
Bulletproof, almost.
The reason it can survive having its blood supply drastically cut is because it doesn't rely on terminal branches. It relies on an incredibly rich, redundant arcade system.
Right. The notes describe it almost like a major highway ring road with multiple on-ramps. You have 4 main arteries forming anastomotic loops along the 2 curvatures of the stomach.
Let's trace them out.
Along the lesser curvature, you have the left gastric artery branching straight off the coeliac trunk, coming down to meet the right gastric artery, which is branching off the hepatic artery.
That's the first loop.
Then, on the long, sweeping greater curvature, you have the right gastroepiploic artery, which actually branches from that same gastroduodenal artery we just talked about, meeting the left gastroepiploic artery, which comes off the splenic artery.
Plus, you have the short gastric arteries also coming from the splenic artery to feed the fundus at the top.
Because all these vessels connect and share the load, you can tie off 3 of those 4 main arteries, and the blood will simply reroute through the remaining connections to keep the stomach alive.
It's an incredible safety net.
Since we are tracing blood flow, let's follow the venous return straight into the liver. The material points out that when we look at the liver, the superficial falciform ligament divides it into right and left lobes visually.
Visually, yes.
But functionally and surgically, that line is entirely useless. How is the liver actually segmented when a surgeon is planning a resection?
The visual surface of the liver is deceptive. To understand the true functional anatomy, you have to look at the plumbing inside.
The principal plane.
Exactly. The true dividing line, the principal plane, actually runs from the gallbladder fossa on the bottom edge straight back to the groove for the inferior vena cava. To segment the liver functionally, you have to map out the hepatic veins.
Right, middle and left.
There are 3 main hepatic veins, the right, the middle, and the left, and they pass upwards through the liver tissue to drain into the IVC at the top. Think of these 3 veins as vertical walls that divide the liver into 4 distinct sectors.
And then the portal pedicles come in.
Yes. Within those 4 sectors, the portal pedicles, carrying portal venous blood, hepatic arterial blood, and bile ducts branch out horizontally. These alternating vertical veins and horizontal pedicles create a 3-dimensional grid,
resulting in 8 distinct, functionally independent segments numbered 1 through 8.
Exactly.
So if a surgeon is performing a true right hemihepatectomy, they aren't looking at the falciform ligament. They are removing segments 5, 6, 7, and 8.
Spot on.
If it's a left hemihepatectomy, they are taking segments 2, 3, and 4, and the notes single out the caudate lobe, which is segment 1, as being totally unique.
It's the rebel segment.
Right. It sits at the back and has its own independent short hepatic veins that drain directly into the inferior vena cava, bypassing the main 3 hepatic veins entirely.
It's completely independent.
This complex venous architecture leads us directly into one of the most highly tested concepts in the material: portal hypertension.
A classic.
When the liver becomes scarred and cirrhotic, that portal venous blood can't get through. Where does that blood go? What are the major relief valves or portosystemic anastomoses that suddenly become clinically relevant?
The crucial thing to remember about the portal venous system is that it has capillary beds at both ends, in the gut and in the liver, and it completely lacks valves.
So when there is a roadblock in the liver, like cirrhosis,
Pressure builds up backward through the entire system. It's like a pressure cooker. The blood has to find alternative routes back to the heart, and it forces its way through tiny, normally collapsed connections between the portal system and the systemic venous system.
the notes list 5 key sites.
The first, and arguably the most dangerous, is at the lower esophagus. The esophageal branches of the left gastric vein, which are part of the portal system, connect with the azygos venous tributaries, which are systemic.
When pressure spikes, these veins engorge, creating huge esophageal varices that can rupture and bleed massively.
Second, down in the pelvis, the superior rectal branch of the inferior mesenteric vein connects with the systemic middle and inferior rectal veins,
Leading to dilated varices in the anal canal.
which patients often confuse with standard hemorrhoids.
The text lists 3 more relief valves for this pressure cooker. The third site is a bit more hidden. It's between the portal tributaries in the mesentery and the systemic retroperitoneal veins.
The fourth is incredibly visual.
You can see it standing at the end of the patient's bed. Portal veins inside the liver connect with systemic veins of the anterior abdominal wall via tiny vessels that run along the falciform ligament to the umbilicus,
When the pressure forces these open, they dilate and radiate outwards from the belly button,
creating that classic physical sign known as caput medusae.
a hallmark of end-stage liver disease.
Finally, the fifth connection is way up top, between portal branches in the liver and systemic veins of the diaphragm around the bare area of the liver.
The surgical implication here is immense.
If you have to operate on a patient with portal hypertension, all of these normally microscopic retroperitoneal and abdominal wall veins are massively dilated, making any incision incredibly bloody and dangerous.
It is a totally different surgical field.
Moving further down the GI tract, there's a concept in the notes regarding the anal canal that is just fascinating. It describes an invisible boundary, roughly around the dentate line.
A great divide.
The text points out that 1 millimeter above this line, the tissue feels absolutely no pain, but 1 millimeter below, it is excruciatingly sensitive. How does embryology explain such a dramatic shift in a single tube?
It is one of the most elegant examples of embryology dictating clinical practice. The anal canal looks like one continuous structure, but it's actually 2 completely different tubes that met and fused during development.
Okay, 2 tubes.
The upper half of the anal canal is derived from the endoderm of the primitive hindgut. The lower half, however, is derived from an invagination of the outside skin, the ectoderm, called the proctodeum.
Endoderm on top, ectoderm on the bottom.
Because they come from 2 entirely different cellular origins, the rules for each half are completely different. Let's look at the lining.
Right.
The upper half, being gut tube, is lined with columnar epithelium, which means a malignancy there will typically be an adenocarcinoma.
But the lower half,
Being modified skin is lined with stratified squamous epithelium, so a malignancy there will be a squamous cell carcinoma.
and the nerve supply, which answers the pain question, perfectly follows that exact same embryological split.
It maps exactly to it.
The upper half is supplied by the autonomic nervous system. It only senses stretch. It is completely insensitive to pinprick or cutting pain.
This is the exact anatomical reason why a surgeon can band or inject internal hemorrhoids right there in the clinic, and the patient feels almost nothing.
The lower half, however, receives somatic innervation from the inferior rectal nerve. It is highly sensitive to pain, touch, and temperature, just like your skin.
Hence why external hemorrhoids are agonizing.
And the material notes that the venous and lymphatic drainage systems are just as cleanly divided, right?
Exactly. Venous drainage from the upper half flows upward into the superior rectal vein, which eventually empties into the portal system.
Downward for the lower half.
The lower half drains downward via the inferior rectal vein into the systemic circulation, which, as we just discussed, forms one of those critical portosystemic anastomoses.
And the lymphatic drainage is perhaps the most crucial point for oncology.
Absolutely. Lymphatics from the upper half follow the blood vessels upward, draining deep into the abdominal nodes along the superior rectal vessels.
But the lymphatics from the lower half drain outward and downward to the superficial inguinal nodes in the groin.
Clinically, this means if a patient has a carcinoma of the rectum that grows downward and invades past that dentate line into the lower anal canal,
The tumor suddenly gains access to a whole new lymphatic highway.
and you will see metastasis in the groin.
That is exactly why we study this. Anatomy drives the pathology. Let's move to the final section of our material, focusing on urogenital and pelvic anatomy.
Let's do it.
There's a classic urology scenario here. A patient writhing in agony, presenting with textbook renal colic. The notes state that there are 3 specific anatomical bottlenecks where a calculus, or a kidney stone, is most likely to impact as it travels.
3 tight squeezes.
Walk us through that anatomical journey. Where are those 3 narrowest points?
Picture the ureter not just as a static pipe, but as a muscular tube, roughly 25 to 30 centimeters long, propelling urine downward. As it descends, It hits three distinct anatomical bottlenecks.
Okay, the first one.
The first is right at the very beginning, the pelvic junction, or PUJ, where the wide funnel-shaped renal pelvis tapers down to become the narrow ureter.
That's spot number one.
The second bottleneck occurs as the ureter drops into the pelvis. It has to cross over the prominent brim of the pelvis, specifically riding over the bifurcation of the common iliac artery.
That physical ridge creates a narrowing.
Exactly. The third, and actually the narrowest point of the entire journey, is right at the end, where the ureter pierces the thick muscular wall of the bladder to enter the lumen.
The vesicorectric junction.
Right.
And just to add a layer of 3D relations to that journey, because the ureter is notoriously at risk for iatrogenic injury during abdominal surgery. As it runs down the posterior abdominal wall, it lies directly on top of the psoas major muscle, and it physically crosses right over the genitofemoral nerve.
Crucial relations.
Now let's look at pelvic surgery specifically. The material highlights a major danger zone during a hysterectomy. Where exactly is the ureter at the greatest risk of iatrogenic injury in relation to the uterine artery?
This is a relationship every pelvic surgeon must have memorized. The critical danger zone is located at the base of the broad ligament.
Deep in the pelvis.
Right. As the ureter travels forward toward the bladder, it passes roughly 2 centimeters lateral to the cervix. At this exact location, the uterine artery, which branches off the internal iliac artery, crosses directly anterior and superior to the ureter as it heads medially toward the uterus.
The classic visualization.
Water under the bridge, where the ureter is the water flowing downward, and the uterine artery is the bridge crossing over it.
Because they are in such incredibly close proximity, when a surgeon is clamping and ligating the uterine vessels to remove the uterus, it is horrifyingly easy to catch the ureter in the clamp or a stitch if it hasn't been meticulously identified and swept out of the way.
It is the trap you never want to fall into.
Water under the bridge. That is a perfect mental image to lock in. We have covered a massive amount of high-yield ground today.
We really have.
We trace the embryology of the gut tube to explain esophageal fistulas and Meckel's diverticulum. We mapped the fascial boundaries that contain a ruptured urethra and visualized the mechanics of direct versus indirect hernias through Hesselbach's triangle.
We walked through the critical borders of the epiploic foramen to understand Pringle's maneuver.
Explored the incredibly resilient blood supply of the stomach and detailed how the liver is functionally segmented by its veins. We visualized the relief valves of portal hypertension, dissected the dual nature of the anal canal based on the dentate line, and pinpointed the exact bottlenecks and surgical danger zones of the ureter.
High yield across the board.
These spatial relationships and functional concepts are the exact facts you need to build your confidence for the MRCS. If you want more rapid-fire revision deep dives just like this one, press follow on the show right now so you never miss an update.
It really helps.
And if you learned something valuable today, if a concept finally clicked or an old blind spot was clarified, please take a second to rate the show.
Before we sign off, I want to leave you with one final provocative anatomical connection from the notes to ponder on your own. It builds perfectly on our discussion of venous drainage.
I love this one.
Consider the venous drainage of the prostate gland. It drains via the prostatic venous plexus, which, as you'd expect, largely flows into the internal iliac veins. However, a portion of this venous blood drains posteriorly, directly communicating with the vertebral venous plexus, specifically the valvulus vertebral veins of Batson.
Batson's plexus.
Think deeply about the implications of this posterior venous pathway. Because it lacks valves, blood can flow backward under pressure, completely bypassing the caval system. It elegantly and terrifyingly explains why prostatic carcinoma metastasizes so early and so specifically to the bones of the lumbar spine and pelvis.
It's a direct route.
Understanding Batson's plexus shouldn't just be a trivia fact for a multiple-choice question. It should fundamentally change how you visualize staging and managing advanced prostate cancer.
That is a phenomenal real-world point to end on. As always, the anatomy completely dictates the pathology. Thank you for joining us for this revision deep dive.
Best of luck with your prep.
We are building these specifically to help you master the material, so we want to hear directly from you. Leave a comment or send us a question about which anatomical region, embryological concept, or surgical system you want us to tackle in the next deep dive. Keep grinding, keep visualizing those 3D relations, and we will see you on the next one.